So good morning, all of you. I hope you all are doing well. And in today's Fellows Academic Round, we have the topic is foot issues in cerebral palsy. And I would like to welcome Dr. Sukhdeep Dulai, who is a very well-known faculty. And I'm thankful to Raman, who introduced me to her. And she is, Dr. Dulai is an consultant at Stollery Children's Hospital in Edmonton, Canada. She's assistant professor of Department of Surgery, University of Alberta. And she is current president of Canadian Pediatric Orthopedic Group. And she had done her training in Children's Hospital, Westmed Children's at Sydney and BC, Vancouver. And she was also a host for the Canadian Fellowship Program run by our own Pediatric Orthopedic Society of India. And Raman is probably the first Indo-Canadian fellow. So congratulations, Raman. Thank you very much for introducing and connecting us to Dr. Dulai. So welcome, Dr. Dulai, and stage is all yours. All the fellows, and we have a mixed crowd of some rehab specialists and some pediatric orthopedic fellows, and few consultants would also be joining down the line, and I hope we'll have an interesting session and discussion. Please move ahead. Let me allow you to share your screen. Yeah. Thank you so much for the invitation. Yeah, I'm not able to hear you. Hello. Hi, can you hear me? Just a moment. So Raman, you are on mute. Raman, can you unmute yourself?
Yeah, I have unmuted myself, sir.
Yeah, I can hear you. Dr. Dulai, can you speak so I can make sure that we all can hear you very clearly?
Your volume is very low, ma'am. Actually, we are just barely able to hear your voice.
Something changed? You heard me okay before and not now?
You need to come more closer, I guess, or like.
Is that better?
Oh.
That's better. This is better.
Okay.
But
all right.
No, so there is some
still
issue. We cannot hear you clearly. So you can look into this your voice input or speaker. So just before, when we were talking, we could listen to you clearly, but I'm not getting your sound now.
I haven't changed anything, so I'm not sure why it's suddenly quiet, to be honest.
Now it is okay.
Better.
Now it's okay.
Okay. All right. So I'll just share my screen. First of all, I'd just like to say thank you so much for the invitation to speak at these rounds. I remember I came to Posy, or went to POSICon in 2020, just before the world got shut down for COVID. And I remember that fondly, meeting so many of my colleagues there, and hope to be back there one day when we're allowed to travel again freely. So Raman had asked me, and I guess Smalin to ask me to speak about foot issues in cerebral palsy. And I'll admit, I have developed a passion for foot issues in neuromuscular patients, just because not only is it incredibly challenging but fulfilling surgery, but you can make an incredible impact on these patients' lives. And it's very intellectually stimulating, because there's a lot of decision making and thought process that has to go into it, and you can apply a lot of principles to it. So thank you again. I will just say, you introduced me as the current president of CPOG. I don't want to take that credit. I'm former president of CPOG, and that's been passed on to Dr. Deb Bartley. be the host of the next CPOG Palsy Fellowship in 2024. And then we'll be hosting our next fellow in 2023. We'll be hosting our next fellow in 2024. If you are interested in that fellowship, please do check the Palsy website and apply for that next year. Okay, so I don't have any conflicts to disclose. Really, I have just a few take-home points, you know, and those would be that these can be really challenging cases. It's very useful to establish a team and to use a consistent, systematic approach that will really help you out with these patients. Remember that no two patients are alike. You can't categorize them just by foot deformity. You must customize your treatment to each patient. And it's really important to understand the foot structure and gait biomechanics in order to achieve successful treatment of foot deformities in these children. I'm going to illustrate those points by an overview, looking at these 5 things, I hope. First is, you know, what are the components of a complete assessment of foot deformities in these children? How do you establish goals of treatment? What are the goals of treatments? What are the common deformities that we see? Detail some of the management techniques that are commonly used, my own kind of thought process and protocol, and then how to avoid some of the pitfalls of management of these deformities. So assessment, of course, you know, the basics that we hear in every single condition is his clinical history, physical examination, imaging, instrumented gait analysis, obviously, are the last being pretty specific neuromuscular conditions or complex deformities. And so let's look at each of those in a little bit of detail. In the clinical history, you should consider the patient's age, right? And normal changes that will occur with future growth, because too early intervention may actually result in overcorrection later, or you may be ending up doing the surgery again unnecessarily sooner than you expected later. The functional level, you know, children with the same deformity of different levels of function are going to be candidates for different types of treatment. And you really want to know, have there been any changes to their functional level? If I see a child who is improving, that's the last kid that I want to go in and do a big reconstruction on right at that time. Because, you know, if they're gaining function and we put them in a cast, make them non-weight bearing for a while, weaken them, then put them through therapy, you're going to not only stall out their progress, but you're going to bring them back. So I always wait till they're plateaued, or usually more often until they actually have some sort of functional impact from their deformity. You have to look at their motivation. If they are not motivated to do, you know, physiotherapy, or they don't have accessibility of those resources, they may not be a candidate for a reconstructive type of procedure that requires that to get a good result. Look at previous interventions and the responses to that. That may help you determine how they will respond to future intervention. Consider what their symptoms are, because those are going to be things that you're going to be looking at trying to improve. Things like pain, skin irritation, are they tripping? Are they not tolerating their brace? Or what are their functional limitations, you know, and what is the patient and family hoping to gain if you were able to help them with surgery, or able to offer them surgery? If those goals are not realistic, you really need to have a serious conversation with them and let them know what you can achieve. Because if their goals are not your goals, if your goal is to get a plantar grade foot and their goal is to have the child running, and that's never going to be achievable, your surgery is going to be characterized as a failure in their eyes before you even start. So you really need to get on the same page with them. And I will probably reiterate that theme a few times in this talk. And the physical assessment, you know, you're going to do a thorough physical examination, obviously, but important to really define tone type. You know, patients with spasticity are a little bit more predictable in terms of their response to surgical intervention than patients with dystonia, per se. And patients with dystonia, I would really caution you when you're starting to do soft tissue surgeries in those patients, because their results can be quite variable because of the unpredictable behavior of dystonia and its response to surgery. Looking for the pattern of involvement. Different patterns of involvement, like a unilateral versus a bilateral, you know, are going to have more likely different types of deformities. Look for both static and dynamic deformities. So that means in your physical examination, you need to be looking at, you know, not only the patient sitting there, but also have them walk and see what happens when they walk. Look for concomitant deformities and issues proximally. Do they have a knee flexion contracture, hip flexion contracture? Do they have rotational malalignment? Things that are pre-positioning the foot in a bad position and will be a problem if you don't address them at the same time, or around the time you, or ahead of the time you do foot surgery. Then you want to assess the flexibility of the deformities in the foot. And so the way I approach the foot, really, and many people do this, is to examine the foot in segments to define those deformities. And I will describe that in a bit more detail just shortly. So for imaging, remember, it's very important that you get weight-bearing radiographs, and that's going to be really hard to do. Not only in the non-weight-bearing patient will I accept non-weight-bearing foot x-rays, and in those cases, I will often try and get simulated weight-bearing x-rays. And sometimes that's not even possible. So if they're really non-weight bearing, then you can't do it. They'll typically have rigid deformities in that case anyways, so your radiographs won't really change. But if they can weight bear, you should try to get weight bearing radiographs. As Mosca talks about in significant deformity, if you're getting a lateral radiograph and the patient has significant deformity in their foot, a lateral of the hind foot is not a lateral of the forefoot. And so, he recommends ordering a lateral of the a lateral centered on the or perpendicular to the hind foot, and then a lateral perpendicular to the forefoot to assess those deformities separately. I'll be honest with you, I tried doing that at my own center, which is a reasonable center, but that's very hard to get reproducible imaging that way. So I've developed alternative techniques to evaluate the radiographs. And it's very important that you also look at the ankle. Often you see a bad planovalgus foot and the ankle's actually in valgus as well. And if you don't address that, that's going to be a problem, because it's going to pre-position the foot in a bad position for recurrence, and also for bad bearing a bad distribution of the weight bearing force across the foot. If I am thinking about doing surgery on a patient, then I will often, especially if it's a complex deformity, I'll often consider getting a CT scan and making a 3D model in the simulated weight bearing. Sometimes it's very helpful when you're dealing with a complex deformity. Not only does it help you kind of think ahead of time, where are the main problems that you need to be looking at in terms of fixed deformity, where do you want to do your osteotomies, where is the cora, especially when you can't get great orthogonal x-rays. But also intraoperatively, when you're doing a long reconstructive procedure, sometimes you lose perspective of where you were at when you started. You're not looking for a perfect foot at the end of these. You're looking for a functional foot that doesn't have the same negative symptoms that the patient presented with previously, or hopefully any new negative symptoms. So I have a model here, for example. This is a patient who has a flat foot and a planovalgus foot, and it's actually a spinal planovalgus foot, because if you look at it, you can see that the calcaneus is tipped plantarly. And how does this help me? I'll talk about that shortly when we talk about foot mechanics. So when we look at the x-rays, or even when we look at the foot clinically, these are the things I look at. I look at the foot in segments. So I look at what's happening at the ankle, what's happening in the hind foot, what's happening at the midfoot, what's happening at the forefoot. And then I describe those separately, because my interventions are also going to be targeted differently to those areas. Then I look at the columns of the foot. What's happening in the medial column versus the lateral column? That medial to lateral balance is very functionally impactful. And so not only will the forefoot medial to lateral balance often dictate what happens in the hind foot, but it also can cause issues at the ankle level. So important to look at that balance. And then I look at the alignment of the arches of the foot. And so considering both the lateral and medial longitudinal arch, as well as the transverse metatarsal arch. So we all know about the medial longitudinal arch, right? So that's the we usually measure it by Meary's angle, so the long axis of the talus and down to the long axis of the first metatarsal on the lateral view, right? Typically, it should be fairly straight. If it's dorsiflex, then we consider that a planus foot, and if it's a plantar flex, we consider that to be a cavus deformity. However, there's also a lateral arch to the foot, and if the lateral arch to the foot is also plantar flex, when the first ray is also plantar flex, and they're plantar flex the same amount, why is that significant? Because the foot is, if you think of the foot as a tripod, that functionally, that means a lot of things. So if your forefoot tips down equally, your tripod is maintained. Your lateral forefoot, your medial forefoot, and your hind foot are all still balanced. And so your foot's not going to tend to tip as much. However, if your first three is dropped, I have another model, I'll just show you. If your first ray is dropped, then you, in order to get your foot planted, down on the ground, so here the first metatarsal is dropped relative to the fifth metatarsal. I don't know if you can see that very well, but there you can see that. This patient, this is when the first metatarsal head hits the ground, the only way the patient's going to be able to get their foot flat on the ground to drop that lateral ray to the ground is also to put the hind foot into varus, right? And so that's going to then pre-position the hind foot into that varus position. So remember to look at not only the longitudinal arch, but also the transverse arch. So when we look at the ankle, we're looking at, is there varus or valgus? Is the ankle dorsiflexion adequate or not? And remember to check ankle dorsiflexion both with the knee flexed and extended. Remember, with the knee extended, you're assessing the gastrocs, and with the knee flexed, you're assessing the soleus. And that's going to help you know what level you need to do a plantar flexor lengthening if you need to do that. In the hind foot, you're primarily looking at, are you seeing hind foot valgus or varus? And so on clinical examination, you look for valgus or varus. Remember that when you're assessing ankle dorsiflexion, always correct the hind foot position to neutral first. If you leave the hind foot in valgus and you say, oh, the patient has adequate dorsiflexion, you have actually overestimated their dorsiflexion, because any varus or valgus of the calcaneus will functionally shorten the ankle plantar flexors. So that's why, even though we say, oh, they're in a ton of valgus, the flat foot looks like they excessively dorsiflex, but we're still sometimes doing a plantar flexor lengthening on them. And that's because when you bring the heel back under the ankle, and you bring this heel back under the tibia where it belongs, it's going to lengthen the Achilles tendon, right, which is inserting here and then has to come down to here. And so really important, bring them into plantar flexion, bring the heel underneath. So there's rare cases where it's rigid and you can't do that, and that tells you a lot too about what you might be able to do surgically. But bring it into plantar flexion, bring the heel underneath the tibia, and then check their ankle dorsiflexion. And the other thing about that is you're looking at what the heel is doing. In a flat foot, you might see that there's a lot of a midfoot break, and you don't want to be fooled into thinking there's more dorsiflexion because you're getting that midfoot break. Okay, so assess the ankle dorsiflexion. Make sure you neutralize the heel when you're assessing that, and look at the heel, not the forefoot when you're doing that, or at least maintain the foot in a rigid position. And then you're looking to see for hind foot. You're trying to see is the hind foot deformity, varus or valgus, rigid, or is it flexible? Is it correctable? Particularly in a cavovarus foot, that can be very significant, because often any cavus foot, as I showed you with that model, any cavus foot will automatically stand with the hind foot in varus. But that doesn't mean you can actually necessarily have to do anything to the hind foot if the driving force is the cavus, but the varus is just flexible and a response to the cavus. So you're going to do a Pullman block, which I have pictures of later in this talk, to determine whether or not the varus is rigid, and that'll tell you need to do something surgically for the varus at the time of surgery. Looking at the midfoot, and another clue on the AP radiographs is that divergence or parallelness of the calcaneus and talus, and I'll show you some examples of what happens in a flat foot and a cavus foot later with that. In the midfoot, you're looking at to see, is the talonavicular joint reduced? Is it subluxed laterally, as it would be? Is the navicular subluxed laterally off the talus as it is in a flat foot, or is it shifted medially on the talar head like it is in a cavovarus foot? You want to look at the lateral length of the cuboid. In a foot that's been quite abductovalgus or planovalgus for a long time, that lateral cortex of the cuboid will be foreshortened. And that can be a significant problem because even after you lengthen the calcaneus, you'll see that you still have a significant amount of abduction. You often have to do a cuboid lengthening in order to correct that forefoot abduction and get the foot realigned. With the goal being, remember, we're trying to get a foot that is stable under the patient and provides a good base for weight acceptance and weight transfer and generation of power during gait, typically for at least for the walking patient. For a non-walking patient, your goal might be something more like, brace tolerance, ability to stand, and comfort. And then the forefoot. So this is where I would look at the forefoot plantarflexion. Do I need to do a dorsiflexion or a plantarflexion osteotomy? Is there a significant bunion which will ruin that ability for that tripod to remain stable? And therefore you want to correct that bunion and restore that. And also a bad bunion will diminish your push-off power. And then look at toe deformity. Sometimes, people do a big reconstruction. This is a learning curve for sure, and leave the toe deformities. And the thing the patient complains about most is, their toes are digging into their brace and uncomfortable. They're rubbing on their shoes, they're uncomfortable. And so I spend a lot of time on that because that's critical. If you don't have an understanding of what's going on at each level of the foot, then you will not be able to do the right surgery for the patient, and you will see a high rate of recurrence in these patients. So the 3D models, like I mentioned, can be useful both pre-op and intraoperatively. The stage of assessment is in our center is instrumented gait analysis. Now, luckily, we do have that abilities. I know not everybody does, but if you're going to be doing, significant complex foot reconstruction in walking patients, especially, I would highly recommend that you try to align yourself with a place that has the ability to perform gait analysis. We have a multidisciplinary team. You can see Raman joined our team this year as our fellow. That consists of a kinesiologist who's also the gait lab technologist, our physiotherapist, as well as a physiatrist or physical medicine and rehabilitation physician, and an orthopedic surgeon, and more than one of many members of this team are included in our overall group. But the key being each of us brings a different perspective to it. We collaborate, we make decisions on the patients together, we look at their gait analyses together to offer different types of treatment and also to consider effects of treatment. We also happen to have a research team with these same people, and I would emphasize that's important because there's so much going on with these patients that sometimes just thinking you've done good with these patients isn't necessarily true, and it's really important for you to go back and look at your results objectively and say what's working, what's not, because I can tell you over my own career that we've changed many things in the way we treat these patients based on review. So the gait analysis, includes a history to assess function and goals, physical examination, looking at spasticity, tone, range of motion, selective motor control, balance, strength assessments, gait videos, so we can do a detailed observational gait analysis, which I think Alaric Rogers has published on doing a simplified version of that in a low-tech setting, which has showed reasonable reliability. So if you aren't in a high-tech setting, at least that is something you should employ. Looking at temporal spatial characteristics, kinematics, so how are the joints moving, kinetics, what kind of power and moment is being generated at the joints, dynamic EMG to see, which is there muscle spasticity out of phase that could be causing problems, and then dynamic pedobarography, which I want to talk a little bit about just shortly here. What are the key concepts in my mind of the foot in gait? Well, of course, the ankle rockers, right? So the first rocker being the heel coming, the heel, you have initial contact with the floor, typically with your heel, and then the foot actually plantiflexes to become flat on the ground. That's the first rocker. The second rocker is the foot dorsiflexing as the tibia advances across the foot. And then the third rocker is when you're pushing off, you're plantiflexing the foot to push off the ground. And all of those are essential in forward progression, in shock absorption and weight acceptance, in weight transfer, and then in push-off generation. And changes to those will obviously affect the patient's function. the hind foot position determines the midfoot alignment. So this is really a really key concept that for me anyways, I think of it, because if your hind foot is fixed in varus, you know, when we first have initial contact in a typical gait pattern, or our hind foot is in varus, and what happens in hind foot varus is that the midfoot, the Chopard joints, are locked because they become unparalleled. So when they're locked, that means the foot becomes rigid, and that's good for when you want to try to, you know, take weight. You want to accept that weight. But then when you want to transfer that weight across that foot, you need flexibility. So what happens is, once we've accepted our weight, the hind foot actually goes into valgus. That unlocks the Chopard joints, they become parallel, and then you develop a flexibility in your foot. That allows the force to come forward across the foot, and then you plantar flex again, the hind foot comes back into varus, and then that force that you generate then goes up and pushes your foot off the ground. So that's normal, right? It's normal for your hind foot to sometimes be in varus in parts of the gait cycle, sometimes be in valgus in parts of the gait cycle. But the key is that it does change. And if it gets stuck in one position, then it's going to affect that ability to do the function of the opposite position. So, and then sometimes they can be exaggerated. So for example, when we see a patient who has excessive hind foot valgus, right, driven by plantar flexor tightness and let's say a diplegic, they get a bit of equinus, and then first they go down, but then, you know, everyone's trying to keep their foot at 90 degrees. So they're pushing up on their foot. Well, what happens? Their calf is tight, so the foot doesn't go. The hind foot goes into a bit of valgus because you got a little bit of laxity at the ankle. And so everyone's always pushing up on it. They push up on it. And then guess what? Hind foot's in valgus. Chopard joints are unlocked, which means they're flexible. And that's when you start developing your midfoot break, right? That's when the navicular starts subluxing off of the calcaneus. So you get sorry, not the calcaneus, my apologies, off of the head of the talus, and you start getting that rubber crowbar that we talk about in CP, right? So where you no longer have a stable base to be able to push off of. All the energy gets absorbed right by the midfoot, and you can't generate power there. So if you haven't corrected hind foot position, midfoot alignment is never going to be achievable, and not at least in a functional manner. The transverse metatarsal arch affects the position of the hind foot. So I talked about that a bit briefly earlier, right? So if the first ray is plantar flex relative to the lateral ray, that's what we call cavus, then that's automatically going to position the hind foot in varus, right? However, if both the first ray and the lateral ray are plantar flexed equally, that's a condition called plantaris, that actually is going to leave the hind foot in a normal position. And that's why we don't usually treat plantaris unless there's shoe wear problems or something, but it's very rare to see actually. But we do treat cavus because it causes those other problems, because the balance of the foot is thrown off, right? In a flat foot, actually, what happens is the first ray becomes dorsiflexed, right? And so that's why they develop the hind foot valgus as well. Now, which comes first, chicken or eggs? I think it's the hind foot in the planal valgus foot, and the forefoot in the equinovarus, but it can go both ways. Yeah, you definitely have seen this. And then toe position can exacerbate longitudinal deformities. So what do we know about toe position? Well, we know that the position of the great toe it is related to the tightness of the plantar fascia, right? So we talk about the windlass mechanism. When we dorsiflex the first toe, it causes the first metatarsal head to plantar flex, but because it tightens the plantar fascia. And so that then causes a cavus type of effect. So if you have tightness of the extensors of the toes, that can be an issue. Or if you have a plantar flexion contracture of your great toe, that could be an issue because it can simulate cavus deformity. And if you're able to offload the toe, you can often see the rest of the foot actually improve in position. You can also exacerbate a dorsal bunion if the toe is flexed. So don't underestimate toe deformities in these patients. Dynamic pedobariography is a very big part of our assessment in the gait lab, and I just wanted to give you some examples of what happens here. So this is an example of a flat foot preoperatively. You can see that, you're seeing that classic rubber crowbar, right? So I'm just going to show you my, hopefully you'll be able to see my mouse here. Okay, can you see my mouse on your screens?
Okay. Yes, we can. Yeah.
Perfect.
Yes, ma'am.
This is the great toe. This is some toe drag up here. This is the medial midfoot. This is the lateral midfoot. This is the heel back here. This line is your progression of your center of gravity. And so you can see here where you should have the medial longitudinal arch, where you should have minimal to no weight bearing, is actually getting the most. So the red and pink is where you're getting the most pressure. The cooler colors are where you're getting less pressure. And we look at it as a function of impulse. Impulse is a measure of force over the time of which it's applied, because we believe it's not just a peak force, but how long that force is applied that actually causes deformity. And we have seen some relationship of that to foot deformities actually. So you can see here that these impulses are shifted to where the midfoot here is taking 10% of the impulse of the foot when it should be at 3%. So that's quite significant actually. And this is obviously not going to be, this is not going to help you generate power very well. So this is that same patient post-op. You can see that, we've improved the midfoot. Now, the impulse is about the same, but you can see that that's the midfoot across, but the medial midfoot, I should have gone back actually and shown you that. Right. The medial midfoot we didn't have in the because this was our older segmentation, I believe. Yeah, unfortunately, I'm sorry to show you that. But I think if you look at the balance, you'll see that the balance is shifted a bit medially. Yeah, so that's where you see that it's 47.8% versus 64. So that shows you that, it looks like it's lateral because of that rubber crowbar, right? But the medial midfoot is still taking more force than it should. Very bad biomechanics for a foot to transfer weight on, right? When you see the post-op, and you can see that you've restored a medial longitudinal arch here. You're getting weight coming across the foot in a more normal pattern here, and you're not having any high pressure points across the midfoot. So this is an example of the equinovarus foot pre-op. This is only the forefoot actually that you're seeing here, and that's because so it looks like, what does it look like? Who knows? But these are toes. This is some toe drag. This is the forefoot. The heel doesn't even come down on the ground, right? Because it's equinovarus. This is the same foot post-op. Is it biased slightly more laterally than it should be? For sure. And so this is where you really want to know, how did the patient do functionally, right? But now you can see that the heel is getting down. You're getting weight across the forefoot. You have a reasonable distribution of your forces. It's another example of a valgus foot. Here you can see toe drag, which is what you're seeing in this 18.9% in the great toe. And this unaccounted is what you're seeing across that midfoot, which shouldn't be taking that much force at all. And then if you look at the heel to forefoot ratio, you can see, that this is really shifted towards the forefoot, because the heel here, you're not seeing a nice contour of it because it's not even getting down to the ground. And that this is the force is really, or the impulse is really shifted towards the medial aspect. This foot, the reason it's different than the one I showed you previously is because it doesn't have as much abductus. The abductus makes the numbers look like everything is more lateral on that previous one, whereas to be honest, in the foot it's still all more medial. And this is an example of how you can improve that, where you're getting less impact across the midfoot. And which really means, less stress on the talonavicular joint, which is what you're trying to get. Another example of an equinovarus forefoot, equinovarus foot, where you're seeing a ton of no heel contact, and you're seeing virtually no. Well, you're seeing all the force coming across the lateral aspect of the foot, or the impulse, I should say. That's because the foot is shifted into varus, right? And this is post-op. Now it's not completely normal. The midfoot is, you don't see any lateral midfoot on this beetle barograph, but you do see a balance between hindfoot to forefoot, and you see your better balance between hindfoot to forefoot, although maybe shifted more towards the heel, which you often will see early on post-operatively when you've done a tendo Achilles lengthening. Over time, you'll see that shift back towards the forefoot, and you're seeing that it's more balanced from a medial to lateral perspective. So Goals. I said at the beginning, setting realistic goals is really important, and this is essential. You have to incorporate the patient's and family's goals, set realistic goals that are compatible with their GMFCS level and available resources. Typically, we aim at surgical intervention to improve function via improving comfort and improving efficiency of gait by correcting lever arm dysfunction and improving stability and comfort during gait. So global principles when we're setting goals is always keep realistic goals in mind. A normal looking foot isn't, let's just say, is not necessarily advised if it means sacrificing valuable motion, right? I would say I would rather keep motion than get a perfect foot, because the consequences of sacrificing motion are significant if the patient doesn't already have arthritic change there, and especially if they still have remaining growth. And same thing with strength. You know, you really have to think about, if you're going to sacrifice strength, is it worth it for the functional gain, whether that be function, comfort, or efficiency. I always use a multidisciplinary approach in making these decisions, do a global assessment of the patient to see if they can tolerate that surgery and the post-op rehab, customize the surgical plan for each patient, and approach the deformities in a systematic fashion. And always think long-term. Don't burn your bridges, right? Don't go for the fusion off the bat and then find out, well, now this patient's got, you know, adjacent joint arthritis, and what are you going to do there? And it gets worse and worse and worse, right? Common deformities, well, we all know these, right? So the common ones are equinus. That's common in all types of CP. And the key about equinus is it drives further deformity if not managed appropriately. And even if sometimes when it is managed appropriately, it will continue to drive further deformity, just because these patients do have progression of their neuromuscular manifestations of the cerebral palsy. It typically starts with the gastrocnemius, but if you have a significant contracture over time, then you can start seeing tightness of the soleus and plantaris as well. Equinoplanovalgus, this is more common in diplegics. Again, always starts out as equinus, and then you get the midfoot break, and then you've got valgus and planus, and then that can become rigid over time. But that's over time, and that's what we refer to as a rubber crowbar, where you can't generate good push-off force because the midfoot is so flexible that it absorbs all of the energy in it as you come across it. And then equinovarus, which is more common in hemiplegics and quadriplegics, and it's a problem because it decreases stability and causes pain for these patients. So you end up needing to manage it. So what are the management techniques? Well, I can't emphasize enough the use of a multidisciplinary approach. You know, whether early on, and even as after you do surgery, that's including physiotherapy for stretching, for strength training, for gait retraining, bracing for maintenance, or sometimes even serial casting to stretch things out, as long as you have a reasonable foot, right? If you do not have a foot that you can control, you should not be trying to stretch the calf muscle, because all you're going to do is cause the foot more deformity. And the use of botulinum toxin injections. We don't happen to do that ourselves. In Edmonton, we have our colleagues in physical medicine and rehabilitation do the botulinum toxin injections. And don't start with surgery. The first time you're seeing the patient, typically, you know, I will always say you need to see where the patient's at, see what they've tried, see what else you can try, make sure their goals are realistic and they're ready to make a big commitment to correction, and really avoid surgery in younger kids wherever you can, because of the high rate of recurrence or overcorrection because of the normal development of the foot. Have a toolbox and customize your treatment for each patient. And I'll kind of go over what my toolbox is in general, although it does change for every single patient. When I'm doing the surgery, I always start with proximal and work distal, just like I do when I do my assessment of the deformity in clinic. I look at correcting fixed deformities first with soft tissue, with bony realignments if I need it, but think soft tissue lengthenings and plications or advancements to maintain those corrections wherever need be. I try to preserve joint motion whenever feasible. If it's in question, I will try and preserve it before I will go to a fusion at a later date if need be. You should consider tendon transfers for rebalancing of dynamic deforming forces to prevent recurrence. So even though the foot might look good while they're asleep, think about what you saw preoperatively and whether or not you need to do any rebalancing there. For equinocalyvarus foot reconstruction, I would suggest, you should be able to do these things and think which ones you need in any patient. So you typically need to do a plantar fascial lengthening for the ankle equinus. You need to do some sort of you need to address the plantar flexors. Typically, this is going to be a tendo-Achilles lengthening because these are usually hemiplegics or quadriplegics, and usually both the gastrocs and soleus are significantly affected. But if it was only the gastrocs and a bit of soleus, you could do, gastrocs with a soleus striping. There's a big debate about open versus perc. There's some people who really believe in the percutaneous. I typically only do open because I don't believe you can control the amount of lengthening you get with the percutaneous, and I can definitely set the open exactly where I want to. I put the foot at 5 degrees of dorsiflexion because I think I can't regenerate the patient's body weight with my own arms. And so I know that they can stretch that out a bit more than 5. I really don't want them to have more than 10 or 15 of dorsiflexion. And that's where I tend to repair my tendon Achilles. The other thing I would say is look at doing a plantar tenotomy if you haven't thought about that before, because it can be a significant plantar flexor problem. And sometimes you have to do a perineal sheath lengthening, especially significant abduction. A lateral calcaneal osteotomy for Achilles, you could do either a lateral closing wedge, which happens to be my preferred, and I add a lateral slide if I get inadequate correction. But you could do the lateral slide instead. The only thing, if you do the slide of the tuberosity, you have to be aware that that can affect the length of your tendo Achilles. So that's why I tend not to prefer that. But if you are going to do it, you need to determine, you need to try and avoid that proximal migration if you've already done your tendo Achilles lengthening, which you typically are going to do before your calcaneus. The tib post lengthening, depending on how much length you need, you can do it intramuscularly or in the tendon, and consider a split transfer to the peroneus brevis. A peroneus longus to brevis transfer, especially if there's significant cavus, will help to prevent that recurrence of the cavus and rebalance the foot. Flip-flop osteotomy, so taking a wedge out of the cuboid and putting a wedge into the medial cuneiform to kind of correct that forefoot adductus. Dorsiflexion osteotomy of the first ray to correct the plantar flexion of the first ray. Toe flexor lengthenings, anytime you correct a marked plantar flexed foot, you're going to have tightness of the toe flexor. Even if you don't see it pre-op, you will see it once you correct the foot position. And abductor hallucis lengthening, that's also going to be tight once you're trying to correct the forefoot adduction. And then possibly a split anterior tibialis tendon transfer to the peroneus brevis if you saw a dynamic deformity occurring there on the preoperative assessment. In an equinoplano valgus foot, I would again start at the back, start at the calf. Typically, I'm only going to do a gastrocnemius recession in these patients because they're bilaterals. I avoid a tendo Achilles as much as I can, and you can always stripe a little bit of the soleus if you need to. When you're doing a gastrocnemius recession, I look to see if I need to address the plantaris. Sometimes I actually maintain the plantaris, so I think that helps me avoid over lengthening. And it acts as a secondary restraint to excessive ankle dorsiflexion. Lateral column lengthening is used to both correct the hindfoot valgus and to reduce the navicular back onto the head of the talus. I do that in the calcaneus because I believe in joint sparing techniques. And so, although some people do describe doing it through the calcaneocuboid joint, remember you are going to sacrifice motion if you do that. An abductor digiti quinti lengthening if there's significant abductus of the forefoot, and a peroneus tertius lengthening should be considered as well in that case. Medial plication, so something that I think most people have seen the tibialis posterior advancement or plication and plication of the medial talonavicular capsule, but not everybody would have seen people do spring ligament reconstructions. That was something we added probably about 5-6 years ago to our protocol because we noticed that it helped to really maintain that medial longitudinal arch and reduce recurrence significantly. So it's something I would encourage people to definitely consider and look into. Doing peroneus brevis to longus transfer, you can consider that, because the peroneus brevis will be short once you correct it. If you're not going to do a transfer, you should at least lengthen it. Do a cuboid lengthening if there's significant abductus after you've done your calcaneal lengthening. Plantar flexion osteotomy of the first ray to deal with that first ray dorsiflexion, right? The so-called planus of the forefoot. Bunion correction. So this is the only one place where I'll sacrifice a joint without blinking, and that is the first MTP, because the results, although some newer literature suggests that perhaps you can get away with a bunion correction, First of all, I'll tell you in significant bunions of NCP, there's significant arthritis and cartilage wear. So I don't see how that's going to be comfortable for the patient. The results that have been shown for just bunion correction without fusion are for mild bunions. And so in anything significant, I would just say go to a fusion and then toe flexor lengthening. So a few additional tips. Okay, you want to do whatever you can to prevent heel sores, but if they do occur, really treat them aggressively. So try and prevent them with really good padding and good management of their spasticity, making sure that they're getting some prone lying time and offloading the heel, and be suspicious. If they're complaining of pain, just take off the cast and have a look. For pain control, think about nerve block catheters or concurrent Botox at the time of surgery to try and reduce spasm. And remember, if you're not sure about whether or not you should do a rebalancing for dynamic deformity, you can always come back and do that later if you're not sure. And in a varus hindfoot, one thing I learned the hard way early on in my practice was at those times when I thought, well, is it okay? Just go for more. You're better off to be in a little bit of valgus in those cases. Otherwise, you have a higher rate of recurrence or residual varus that causes you problems. Remember to always splint the knee in extension when you have the patient in a below knee cast postoperatively after you've done a plantar flexor lengthening, because otherwise the gastrocs is going to get tight. You want to do some intensive PT after cast removal or once they're permitted to weight bear, because you want to gain their function back as quickly as possible. And like I said, reserve effusions for rigid or mature feet or where arthritic change is already present. Just a few examples. So this 11-year-old girl with diplegic CP, you can see here, I think you can see my mouse. So you can see that on the AP view, the talar head is uncovered medially because the navicular is subluxed. You can see Miri's ankle is broken with the talus plantar flexed with the and the first ray dorsiflexed. There's a little bit of a bunion there. This patient underwent a tendo Achilles lengthening, lateral column lengthening, which you can see here through the calcaneus, peroneus brevis lengthening. And then they also had a first MTP fusion with the tibialis posterior talonavicular plication and spring ligament reconstruction. So this is the first MTP fusion. We originally fixed and then fixed it with the plate. These are intraoperative simulated weight bearing views. This is a year post-op. A pretty good result for a patient who had a terrible foot preoperatively. This is an example of cavo varus foot. This one, the 13-year-old male with left hemiplegia. This patient underwent a tendo Achilles lengthening with plantaris lengthening, peroneal sheath lengthening, calcaneal lateral closing wedge osteotomy, FHL lengthening, plantar fascial lengthening. So I list all these here just to tell you it's a huge case and you got to do it step by step. And it's nice to have a teammate, right? And now we fixed this child with pins, which we rarely do, but that was because the bone quality was so poor. This is him a year later. You know, does he have a little bit of residual cavus? Sure, but when we look at that pre-op film, you can see that squaring off the talus. You can see the hindfoot's off the floor. Terrible foot. At least he's able to get his foot down. He's comfortable. You can see at the talar neck, he doesn't have that normal concavity because he was in equinus so long. One thing you have to warn patients who've had long-standing equinus about is that they might have impingement symptoms afterwards. This is a diplegic CP. Terrible planovalgus foot. I just wanted to show you these films because this patient, it was elected to do a first metatarsal osteotomy instead of a cuneiform osteotomy. Well, the only issue with that is that you just have to realize you're going to have the zigzag deformity on the lateral afterwards, and that's because the cora of the deformity in a flat foot is not in the first metatarsal. It's actually the talonavicular joint. The closer you can get to that, the more normal a contour you're going to have, right? And then this is a cavo varus foot. And the only reason I wanted to show this to you is because we actually decided to do guided growth, which we can do of the first metatarsal. You have to make sure that the hindfoot is supple, and this patient's was. We did a soft tissue rebalancing, and she grew into it. She stopped growing a little bit too early. I would have liked another year. It would have been great. Just a few technical tips. Identifying the peroneus longus. So you can see my fingers there on that picture on the right, where my thumb is. You just push up on the first metatarsal head. Only the peroneus longus will move, and you'll know exactly which one is which. Although if you have that much exposure as we did in that particular one, you should know which one is which. This is an example to show the role of the plantaris. Top left. There's the Achilles and plantaris tendon exposed. In the middle on the top, the tendo Achilles has been Z lengthened, not repaired yet. You can see the plantaris is still intact. And then on the top right, you can see that's the maximum ankle dorsiflexion with the tendo Achilles divided, okay? In the bottom, you can see I then divided the plantaris tendon, only the plantaris. That's the only thing we did between the top and the bottom. And you can see how much gain in ankle dorsiflexion we got. Do not ignore the plantaris. Have a look at it. See if it's a problem. Sometimes it can help you. Assessing hindfoot flexibility. Look, this patient has significant cave of varus. You can see in the standing position on the left side, he's in varus. We put him on a block, offloaded the first tarsal head. You can see the hindfoot varus corrected. This is a patient who also has cave of varus. Put them on a block, only partial correction. So this patient is going to need the hindfoot addressed, whereas this patient is not going to. Just need to correct the cavus of the have a great surgical team you can rely on. There's Raman who joined me and my partner in complex foot surgery, Dr. Angela Scharfenberger, for some of our cases this year. You know, just so you can throw ideas back and forth with one another, and she's an adult foot and ankle surgeon, so we can share techniques with each other that I don't necessarily commonly use, or that she doesn't necessarily commonly use, and we can implement them both in our patient. Take-home messages, remember these can be challenging but very rewarding cases. Establish a team and use a systematic approach. No two patients are alike. Customize your treatment to each patient, not to just to each deformity. And understanding of foot structure and gait biomechanics is essential to successful treatment in these children. This is Edmonton. It's a beautiful city. We'd love to have you come and join us sometime if you can make it. So if you're thinking about a fellowship, please apply to the CPOG Palsy Fellowship. And if you are coming to Edmonton, please let us know. Thank you so much. I'm sorry I went a little bit over time. It's a lot, maybe a lot over time. It's a huge topic, so I'm so sorry about that.
Yeah, that's fine. But that was wonderful talk, and you covered all the aspects of neuromuscular foot, and especially you mentioned the importance of X-rays, which we should use more often. Now, a few questions like what are the indications, clinical indications for cuboid lengthening? Because we used to do only calcaneal lengthening for planovalgoid. So when you decide to do cuboid lengthening?
So if I've done the lateral column lengthening and then I look at the foot and there's a significant amount of abductus of the foot, and when you look at the AP X-ray, often what you'll see is that the lateral cortex of the cuboid is shortened. You know how normally it's actually quite lengthy, and you'll see it foreshortened there. In those with that residual abductus, I will do a cuboid lengthening.
And then how do you do the peroneal sheath lengthening? So you mentioned peroneal sheath lengthening. So what's the technique of doing that? How do you do that?
So I would make an incision. So I'll show you on the foot model a little bit higher. So if this is the fibula, make an incision about this level. Typically, I mean, if I have an open Achilles, then I can always do it through that incision. I just find the peroneal sheath, and then I do cut this sheath transversely, actually.
So transversely.
Yeah, exactly. And or the same thing here, but through a small mini opening. I don't.
Right. So let me see. There was one more question about. Just a moment. So any question, or please raise your hand. Yes, Chinmay, please.
Hello, ma'am. I have one question. As you mentioned about the dynamic pedography before assessing the foot, sometimes we don't have a facility to assess on dynamic part. So if we get a static static pedography, so is it helpful to evaluate for the surgical planning?
Yeah, you know, they're very different, right? They're very different because a patient may stand one way, but that's not necessarily what's happening during gait, right? What's happening in terms of that function. Because I mentioned to you that, you know, the foot actually changes shape, right? As you sit. We look at impulses, which is a product of time and force, which you really wouldn't apply in a static pedoporography. But listen, I would say if that's the best you can get, then at least some information is better than no information. But it's not going to give you, it's not going to give you an idea of where the ground reaction force travels, right? It's not going to give you an idea of how the foot is changing. So that's the big difference.
Sure. Thank you.
They just asked to explain the unaccounted force again.
Okay, so I didn't go to, maybe I shouldn't have included those impulse tables because it's a little bit confusing for anyone who hasn't seen it.
Mm-hmm.
But basically, you know, when we segment the pedoporography, the footprint, I guess, right? We segmented it in different areas of the foot. We segmented it into areas that we think are functional areas in the foot. what the unaccounted is areas that weren't included in that, what we thought were the most functional areas, what most people consider the most functional areas. And that is grouped when people talk about beta barography as the unaccounted area. You can go back and analyze where that unaccounted comes from, but basically it tells you areas which normally shouldn't be taking a lot of force are taking a lot of force.
Yes, Dr. Sunny, please.
Good morning, ma'am. Good morning, sir. Ma'am, I have a question that if you plan surgically that this is the surgery which will be done for the foot, how often does the dynamic pedogram alters your clinical decision, ma'am?
I think that, so I don't plan typically like without it. So I wouldn't say it's necessarily altered. I think that it's useful in a few ways. I think that, like, if you don't have it, it's not that you can't do surgery, right? Let's be honest about that. You definitely could. I think that one, it allows you to, I'm a researcher as well, so it allows me to objectively look at the results of a surgical intervention and say, did this actually help from an objective perspective or not, right? But I think that sometimes it'll highlight to you slight differences that you're not necessarily appreciating clinically. So, if you saw, if you thought, oh, well, this patient has a tight Achilles, but oh, look, they're really coming down a lot in their heel. Why is that, right? You might not see that clinically. And sometimes some of those differences have to do with what's happening proximally. So it'll make you go look harder for something that's going on up above, or it'll give you a clue that maybe the patient doesn't have the power generation capabilities that you think they do. And you should be very careful about doing lengthenings that would exacerbate weakness. So I think there are a number of ways it can help you, but I think that if you don't have it, then you do the best with what you have, right?
Thank you.
Okay, so let's take one case. Sheenam, can you share your screen and present the case? And we'll have a few more questions, which I'll ask Raman to pass on to you. You can answer
Sure.
that at your ease, and I'll post it in our WhatsApp group of fellows. Let's go through this case and we'll discuss it further. Yeah.
8-year-old male came to us with complaint of abnormal walking pattern. He was born at preterm at 28 weeks via C-section. Didn't cry immediately. There was history of NICU stay for 1 week. He was having delayed milestones. He started walking at 3 years of age. There were callosities along the lateral border of foot. We can see here forefoot adduction is there and hindfoot cavus is there. And equinus deformity at ankle is also present. We can see in the coronal plane, he is walking with retracted right upper limb, and we can see there is forefoot adduction and equinus deformity. In the sagittal plane, we can see in the stance phase also there is knee flexion. And equinus deformity is very apparent.
So can you, Sheenam, can you go back to the video, please?
Yes.
And so Dr. Dulai, how would you ask fellows to read these videos?
Right.
Or any specific points you would like to point out?
Yeah, so if I saw this patient, actually maybe let's go back to the coronal view first.
Yeah, can you go a slide back, Sheenam, please? Yeah. Go back to the coronal plane and play it. Yeah.
So, I always say, and I'm sure you guys do this too, right? Have a system and when you're looking at gait analysis, right? But let's just focus on what's happening in the lower limbs in this patient. So you said that pelvis is retracted. I would say that's a hard call to make from this particular video. He's definitely vaulting because he has a functional limb length discrepancy due to the equinus on the right side. right? You can see that. And you mentioned, you know, is he keeping the knee excessively flexed? Well, that's probably the big question is that a compensatory mechanism for his limb length discrepancy in addition to the vault, or does he have a primary problem at the knee? We'd have to figure that out, right? The other thing I would say is, okay, not only is he in plantar flexion, right? But he's also in toeing, right? His internal foot progression, but he is clearing his toes. He's not tripping, so that's an important thing to recognize.
Sagittal pain, please. Yeah.
Yeah. And then the only other thing I would say is, you know, one other thing we notice often is in these equinovarus feet, you see the foot pivot a little bit as they come across it. And that's just because of that limited area we think that they have to balance on. He's not too bad on that regards though.
So based on this clinical video, can we judge? Of course, we have to follow this with clinical exam, that whether tip post is functioning more or the T-band, because in this centers, you know, we don't have a dynamic instrumented gait analysis.
Yeah.
And we rely heavily on clinical exam and the gait videos.
Yeah.
So the clinical sign, can you play the coronal video, Shinam? So we term it as a tibialis posterior thrust. If we carefully look at the foot.
Mm-hmm. Okay. You notice how I tried to avoid talking about that in my talk, right? So I know, and that's because, you know, that's probably one of the hardest things is to know when is tib-ant the problem, when is tib post the problem, when they're both the problem. So this is what I would say to you. This patient has very marked plantar flexion of the ankle, which tells me already the tibialis posterior is definitely going to be a problem that you're going to have to deal with. Now, the question that always comes to me then is, well, what do you do? A transfer or a lengthening? That's an easy answer actually, because once you lengthen the plantar flexors, you will know, do you have adequate length in your tibialis posterior or not, right? You are definitely gonna have to do something in the tibialis posterior here, but if you don't have adequate length, you're gonna be doing a lengthening. And then you'd have to decide, do you have enough imbalance of the tib-ant to transfer? That could be a decision you wait to see what happens post-op and come back and do a quick transfer on the patient later. Or if there's enough length, then you should for sure do a split tib post transfer. Yeah.
Right. So the other issue is many a times the patients are coming from pretty far, and at times they want things done in one stage.
Yeah.
Although we know it's wise to stage procedures to prevent overcorrection, but sometimes we are compelled to do everything in a stage. So I agree with what you have mentioned for this gait.
Yeah.
So we are dealing with, we have to check the tendo Achilles. Most probably this is pretty short, looking at equinus, tip post, as you said, and we have to see whether this cave is.
Toe flexors, you'll have to do a plantar fascia lengthening on this patient for sure. You probably will have to do a calcaneal osteotomy on this patient. You probably will have to do a first ray osteotomy to bring the toe up, right? And I would say if you had to go in one go, I'll tell you what we do in those cases. Then we hedge our bets and we say, okay, lengthen the tib post and do a split transfer of the tib-ant. As long as you're doing a balancing transfer and not a complete transfer, you're unlikely to overcorrect. So just do a split transfer of the tib-ant to peroneus brevis, and then if you wanted one surgery, that's what I would say.
Right. So this is a time when Dr. Vince Mosca visited us, and I attended his workshop. And we had a bit of discussion about considering peroneus longus to brevis in some of these cases. So Shinam would share the clinical exam and we'll show what we have done, and then you can comment. Yeah, Shinam, can you move ahead and show your clinical findings? Yeah.
Hip abductor spread was terminally restricted. There was no hip fixed flexion deformity, and rectus femoris, there was also no spasticity of rectus femoris. Popliteal angle was 40 degree on the affected side, and on the normal side, it was 20 degree. There was no change with popliteal shift. Silver skyall test was positive. With knee extension, it was 15 degree. tibialis posterior spasticity was
It
present.
was, I would say the silver score would be partly positive because it's a contracture. There is not much change in knee flexion and extension. So there was contracture of tendo Achilles. And tip post, as you mentioned, when we try to evert, there will be jetting out of the tip post from behind the medial malleolus. So tip post spasticity was there. And rotational profile was not. Yeah.
Was there a fixed flexion contracture at the knee or not?
No, it was not. It was a dynamic spasticity with R140 and R2 around 35. It was tighter than the other side, and there was no change popliteal. So, yeah, there was no flexion deformity.
Okay.
Coleman block test was done to differentiate between flexible and rigid deformity. And on keeping the block, it was correctable, and axis was in line. Achilles tendon and heel was in line, so it was partially correctable.
There was probably the secondary hindfoot varus rather than the structural deformity.
Right.
Now, question is how should we proceed? Should we do only a soft tissue procedure or soft tissue procedure and bony procedures, or only bony procedures, as it is not rigid deformity?
So let's stop, and Dr. Dulai, you can again, I understood, but the fellow's understanding, based on this examination, how would you approach this child?
Right.
And in which order would you approach hindfoot first or forefoot or?
Yeah. So I always go to the hindfoot first. I always work from the back to the front. You don't know where the front should be until you know where the back's going to be. So for the fellows, I would just get that in, just follow that system. So this patient definitely needs her plantar flexors addressed. I consent every patient with this much deformity for both soft tissue and bony. And I tell them we're going to do what needs to be done to get the foot to the position we need to get it to. So you're not committing to, you don't need to do the bony. You see that, wow, you get a tremendous response to soft tissue. Sometimes we stop at the soft tissue, and that's what I would say. But I would do the plantar flexors first, address the tendo Achilles, obviously in this case, because the silver spolt is negative, and there's very marked plantar flexion contracture actually in this patient. When there's that much plantar flexion contracture, there's going to be a definite tightness of the tibialis posterior, which you're not necessarily going to be able to examine preoperatively, because you can't dorsiflex the ankle, right, past where the Achilles lets you get to. So, but you will see that once you do the correction. And so I would start with the plantar flexors, then go to the hindfoot. So in my hindfoot correction, I would look at what do I need to do for the tibialis posterior? Is there enough length or not? If not, I would lengthen it. Then I would look at the calcaneus at that point in time. Does the calcaneus correct to a slight valgus position once you have done your plantar flexor and tibialis posterior procedure? If it does, then you do not need to do a calcaneal osteotomy. If it doesn't, then you need to do a calcaneal osteotomy, which I would do a lateral closing wedge for that. So then I've dealt with ankle and hindfoot, right? And then I would say, okay, now let's move on to the midfoot and the forefoot. So I would look at that adductus. Is there significant fixed adductus of the forefoot? If so, I would do abductor hallucis lengthening, and then I would consider doing a flip-flop osteotomy. So a shortening of the cuboid, lengthening of the medial cuneiform, correct that forefoot adduction, only if it's there after I've done the hindfoot, and I think it's a significant problem. And then I would look at addressing the first ray. I'm going to say that this patient probably needs a plantar fascia lengthening. I would probably do that actually before I did anything after the Achilles tendon. If I know they have significant cavus, I'm going to do the plantar fascia. I do it through a plantar incision, actually oblique right over the plantar fascia, just distal to the calcaneal tuberosity. And then so then I would move to the first ray, and then I would look at the toes. this patient, when you bring his foot up, my guess is every case I've seen, those toes scrunch down because they're also tight. They're coming behind the medial malleolus, right? And so you're going to need to do toe flexor lengthenings on this patient. And then I'm thinking about dynamic. So that's where I would come back to, do I think that that there needs to be a transfer if I didn't lengthen toes, which I think in this case you're going to have to. Maybe I'm wrong. I never know when cases are getting presented to you. So, but if you didn't have to lengthen the tib post, and you would think about a split transfer. If you did have to lengthen, I would think, do I need to do a split tib-ant transfer? And I would also think about doing a peroneus longus brevis transfer in the patient to try to to avoid the recurrence of the cavus.
So let's show what we have done, and then I'll ask that how would you make a decision that whether you want to do T-band split transfer or you would do a peroneus longus to brevis. Is it based on your dynamic EMG, or how would you make a decision on that?
Yeah, that's a great question. I mean, I definitely do use dynamic EMG to look for out of phase or significant spasticity of the tibialis anterior. I look for, what the thing I actually use the most, and you guys would have this available to you, is get a good video, right? If you're seeing that forefoot supinate, even when they're in plantar flexion, if you're seeing it supinate and swing, tib-ant's probably a problem, and you're going to have to do something about that. If you're not seeing that, even if you don't have EMG, I'd probably be a little more hesitant to do it, unless I thought, well, I still think that this foot was trying to pull in. But that's unlikely, because your tib-ant is going to be lengthened quite a bit when you're that plantar flexed, right? In fact, people talk about when you're correcting that much plantar flexion, should you actually do a tibialis anterior advancement to actually improve the dorsiflexion strength? So I mean, I think I would do the longest to brevis because he has a lot of cavus, and that's a problem for him.
So the another issue is that why I'm in bit fear of doing split T-band. At times they have weak dorsiflexors because of long-standing equinus, and so we am in fear that we might make it more weaker, Anyways, but we'll show what we have done. Shinam, can you quickly go through the? Yeah.
The technique of advancement actually talks about transferring and tightening it, right? To try to improve that. So that is something that could be considered.
Yeah, that is right. Shinam, show us what we have done.
Yeah, nice.
We performed percutaneous plantar fascia release, medial cuneiform plantar opening wedge osteotomy.
So after plantar fasciotomy, we found that the cavus was fixed and persistent. So with the plantar opening wedge osteotomy of the medial cuneiform, and as Shinam has mentioned, we did sliding TA tenotomy because it was 15 to 20 degree contracture. And after that, also the hind foot is going in. So tip post was tight. And the next step, we did a tip post fractional lengthening. Yeah, Shinam, go ahead and show.
Aponeurotic lengthening of tibialis posterior was also performed. Then we transferred peroneus longus to peroneus brevis muscle.
So to just take over the peroneus longus, pull on the first metatarsal. And as I mentioned, I had a bit doubt about T-band strength, so I prevented doing T-band transfer, but that's a great idea to tighten it so that it gives an additional strength. Where some of these children have weak dorsiflexors even after doing foot balancing, and then we have to come back in the second stage.
Yeah, John Daly did publish on that to show that T-band transfer after plantar flexor length, or not transfer, advancement actually improved their dorsiflexion power during and clearance, right? So
let's show the video, and probably this candidate might need that in future. So this is about 6 months, but I see some circumduction because of the weak dorsiflexor.
Yeah, his toes dropping, right? So is he?
Show both the videos, please. Yeah.
I mean, he's clearing his toes, right? But what I do notice is that his great toe seems to be excessively plantar flexing. That's something sometimes, you know how we see in club feet where they develop a dorsal bunion, right? Which would be odd in his case because you didn't do the surgery that should cause that, but it might be just some intrinsic imbalance. And that's one thing we've been looking at a lot lately is, you know, I think in large part, foot surgery has ignored the role of the intrinsics in CP, but they probably are more significant than we appreciate, right? And but I think overall, I mean, look, he's got more stability. He's only 6 months out. He should gain strength still with time, right?
Yeah.
Did you brace him? Are you bracing him, or what's the plan with?
So he has been wearing an AFO. For 3 months, it was a static AFO. Now we have made it a hinged one, so that he can climb and recline the stairs. So family is very happy. Some of the time they are very happy when the heel is down. But when we see this video, we always find something needs to be done further. And I feel that the ankle dorsiflexion strength is less, so he has a bit of high steppage gait, and we have to add something. And there is very subtle dorsal bunion happening, because although tibialis anterior is weak, the peroneus longus, when we take off, what now I do is once I cut it underneath the fifth metatarsal, I do not leave this distal segment loose. I tie with the periosteum of the fifth metatarsal, because otherwise there will be no it's a static reinforcement to the plantar flexion of first metatarsal. Otherwise, they are high likelihood of developing bunion. So in a few of my early cases where I found this bunion, I used to just cut it and leave it. But now I tie it with the fifth metatarsal plantar periosteum. So there is some restraint, you know. What do you do for that?
No, I've been varying, but to be honest, what the latest thing that I am doing and think, I mean, I have varied. Raman will tell you that, but because I've been thinking about different ways to do it. But I think that the one technique that I have recently come across that I think would work really nicely is where you take the peroneus longus and brevis and you do a side to side repair, basically a tenodesis, and you don't necessarily cut the rest of it, but because it's attached to the peroneus brevis, the length between where it's attached to the brevis and the longus becomes defunctioned, but it's at a fixed length, if that makes sense, right?
Okay.
It can't get longer, but it won't be pulling on the first ray as much. So I can't speak to the results of that yet because I used to do what you said. Like I used to transfer it and then cut the rest of it and say, okay, I let it go. I didn't see this problem. I didn't see dorsal bunions, but I've always wondered about it because I thought, you know, you're leaving it without anything. But I'm pretty selective in the patients who I use it in. So, yeah.
So and some patients, what I've done is flexor tendon is inserted to the neck of the first metatarsal, you know, it's a transfer so that it will pull it down.
Like
in
it's
very severe cases. But this child did well.
He has a beautifully braceable foot, you know. So I think for my goals, I would say he's doing well, and he's only 6 months out. Hopefully, he'll gain a little bit of strength. You know, like I said, the only thing I would do, probably would have done differently, and that's just my own technique preferences. I don't do perk lengthenings because I just really don't feel confident that you can control the amount of lengthening. But Raman tells me in India and other places they can control it. so I trust it's better in other people's hands, perhaps.
So now it has been 2 years since we have operated this child. He's doing well. I've asked him that we might need this surgery. So probably because, as I have mentioned, that he needs further surgery, they are not coming in follow-up. They are happy with what, maybe this child, as he turns into adolescence, he'll come back with some other issue, and then at that time we might have to address it.
Yeah.
But I'm glad that we too follow the principles by and large. What we don't have is a instrumented gait analysis, and we can do static pedobarography, but that's a boon in itself because we spare a lot of time in clinical exam, and we ask fellows to learn the key to understand the how to take video, how to analyze them, take it in slow motion and all, Anyway, so
I would say you should look at dynamic pedoporography. That's the only thing I would say. It's not that much more expensive usually. You do need someone with a little bit of expertise, but if you got a regional expert, that might be something that you could be centralized somewhere, right? And it's not as expensive as doing a full gait analysis, that's for sure.
So for this, like I do a lot of brachial plexus palsy upper extremity work. And for that, we have liaised with Indian Institute of Technology in Gandhinagar. So we are trying to learn this motion analysis for upper limb. And the similar things, they all have this pedobarography machines and they can very easily do it.
Yeah.
But yeah.
You can have it in your office. It's $300. I don't know what that translates to in rupees, but and then they can just walk across and you can send the data to your technologist.
Yeah.
But it is helpful if you can get it. But there are people that don't have it, right? And it doesn't mean you can't treat the patients.
So I thank you very much for your valuable time, and I'm sure there are many questions which fellows, some of them are shy to ask, but they will put on my WhatsApp group and then we'll send it across.
By all means.
Thank you very much. Thanks, Raman, for connecting us.
Thank you, sir.
And
It was
we
a
all
really
enjoyed
talk.
this.
Thank you, ma'am. Thank you very much
Thank you,
for
ma'am.
your precious time.
And
Thank you, ma'am, so much.
We'll catch you if you happen to visit India sometime.
She's coming next year.
Okay, that's very good.
Somebody let the cat out of the bag.
Or in 2025, I'm going to organize PalsyCon in Ahmedabad. So maybe at that time we may connect. Yeah.
That'd be great. That'd be great.
Okay.
I look forward to it. Thank you again.
Take
Thank
care.
you, ma'am.
Bye-bye.
Thank you so much.
Okay. Thank you, everybody.